Welcome to a general review about chronic oxygen therapy and a practical clinical case. Today I'm going to present Doctor, I'm breathing fine. This title reflects something we often clearly hear in clinical practice, even in patients with significant hypoxemia. This highlights the gap between symptoms and objective severity. The clinical case is an 82-year-old male transferred from the Intermediate Respiratory Care Unit for continued management and rehabilitation. He has had multiple prior admissions with a clear indication for chronic oxygen therapy, which he has consistently refused. This refusal is key to understanding the case. He presented with oxygen desaturation in a public setting along with general malaise and fever and tested positive for COVID-19. A trial of oxygen therapy was attempted but poorly tolerated. On examination, he had basal hypoventilation, mild bronchi, more prominent on the left side, no peripheral edema initially, and a known atrial fibrillation, which was present with an irregular rhythm in the heart auscultation. His past medical history is significant. He has COPD GOLD3E phenotype, bronchiectasis, and chronic respiratory insufficiency. He is a former heavy smoker until 2021 and worked in a coal mine for many years, contributing to his lung disease. Cardiovascular comorbidities of this patient include heart failure with preserved ejection fraction, atrial fibrillation, and a moderate aortic stenosis. He also has typical metabolic comorbidities such as diabetes, hypertension, and dyslipidemia. From a respiratory perspective, his forced expiratory volume in 1 second was 36%, consistent with severe obstruction. His diffuse lung carbon monoxide is moderately reduced, and his baseline oxygen saturation is already borderline, between 88 and 91%. Importantly, he has frequent exacerbations and at least one hospital admission per year over the last 5 years. So this is clearly a high-risk COPD patient. Imaging shows chronic structural lung disease, including bronchiectasis. We are going to show a CT scan about that, and bilateral involvement. His occupational exposure may also contribute to the bronchiectasis and mixed phenotype, not just a classic smoking-related COPD. There are no clear acute focal findings, but the images support advanced chronic respiratory pathology. Here we have the CT scan in which we can see the bronchiectasis, which are more prominent on the left side. Also, a dilated heart is present on this slide. Current treatment include an already optimal inhaled therapy with triple treatment, LAMA, LABA, and inhaled corticosteroids. He is also on azithromycin prophylaxis, diuretics, and uses rescue bronchodilators. Despite this, he continues to require frequent antibiotics and systemic corticosteroids. Even though he is on maximal therapy, he remains unstable. During this admission, the diagnosis was a COVID-19 infection with COPD exacerbation, leading to an acute on chronic respiratory failure. Importantly, he has advanced COPD with a clear indication for oxygen therapy, which he continues to reject. However, he has severe COPD with chronic hypoxemia and indication for oxygen therapy. although he refuses the treatment. Why is this? Socially, he is divorced and he lives with his mother-in-law. In fact, he actively avoids being at home, which is the only place where he can use conventional oxygen therapy. So even though having a clear medical indication, the issue here is not only clinical, it is also behavioral and social. This creates a major barrier to adherence, especially considering that he already required more than 15 hours per day, and now, with established core pulmonale, which was studied by echocardiography, the indication would be closer to continuous 24-hour oxygen therapy. So, he is a Goal 3E exacerbating patient with high exacerbation burden, chronic hypoxemia, and established indication for oxygen therapy. He also has significant cardiovascular comorbidity, including core pulmonale, which is a criteria for nearly continuous oxygen therapy requirement, and this combination places him at a very high risk. The clinical course was the following. During admission, he presented with tachypnea, dyspnea, and peripheral edema. Treatment included intensification of diuretics, corticosteroids, oxygen therapy, and antibiotics. He showed progressive respiratory improvement, allowing reduction of oxygen flow to 2 liters per minute. However, he still required continuous oxygen therapy. During admission, he also developed a urinary tract infection with Enterococcus fecalis, treated with nitrofurantoin. Here we can see the summary of the complications during the admission and the UTI that appeared in this patient. He was waiting for outpatient urology evaluation of benign prostatic hyperplasia. The plan before initiation chronic oxygen therapy include optimization of bronchodilator therapy, but he was on maximal therapy already. We use systemic steroids and reassessment of oxygen therapy indication. We have to follow up with pneumology and cardiology department, and we arrange that for an outpatient setting. So, what is COT? Chronic oxygen therapy is defined as oxygen administration for at least 15 hours per day in patients with stable chronic hypoxemia. Its main goals are to improve survival, reduce dyspnea, and improve quality of life. Indications for COT are very specific. In stable patients breathing room air, a partial pressure of oxygen or of 55 millimeters of mercury or less, or between 56 and 59 if there is evidence of core pulmonale, polycythemia, or right heart failure. The target saturation is at least 90% or 82 to 92% in hypercapnic patients. These criteria are crucial. This is where survival benefit exists. So, in this context, we're going to speak a bit about portable oxygen therapy. The indications are the same for continuous oxygen therapy, but we have to arrange it and prescribe it in patients with active lifestyle outside the home. This patient meets criteria for long-term oxygen therapy, but his lifestyle makes adherence to stationary oxygen very difficult. In this context, particularly portable oxygen therapy becomes very relevant. Given that he spends several hours per day outside the home, portable oxygen could be a practical solution to improve adherence. So, portable oxygen is not just a convenience for this patient. It may be the only realistic way to achieve adequate treatment exposure. Portable oxygen is indicated as we have seen in patients who already meet the criteria for COT and have an active lifestyle. It requires demonstrated adherence and regular activity outside the home. Oxygen is usually started at 1 liter per minute and titrated to achieve target saturation. Requirements increase during exercise and sleep. The key is to identify the minimum effective flow and reassess periodically. The hours needed are very important. The minimum duration is 15 hours per day, but ideally between 18 and 24 hours. Less than 15 hours per day does not improve survival. This is one of the most important messages. The flow estimation, we will start at 1 liter per minute. We will titrate to target saturation of oxygen of above 90% and record the minimum effective flow. In exercise, we should increase 1 or 2 liters per minute. In sleep, about half to 1 liter per minute. And we always have to monitor adherence and reassess periodically. Chronic oxygen therapy improves survival in severe COPD patients. This is supported by classic trials like NOT and MRC clinical trials. It also reduces dyspnea, improves exercise tolerance, and decreases right heart strain. However, there is no survival benefit in mild hypoxemia. There is strong evidence in severe COPD patients, according to the GOLD guidelines that have studied the clinical trials of NOT and MRC. Potential risks include hypercapnia, nasal dryness which can lead to nosebleeds, psychological dependence, and fire hazard. Should not be prescribed without documented hypoxemia, and adherence is essential. The contraindications, as I've already said, is non-demonstrated hypoxemia, the lack of adherence, even though this is a relative contraindication, active smoking, which oftenly is a challenge to achieve because we usually have to negotiate with the patient that they should stop smoking, or at least if they don't stop radically, they shouldn't smoke near the oxygen bottle, not in the same room, and if they can, do it outside the house when they are on oxygen therapy and they have the material for oxygen therapy. The use exclusively in dyspnea without hypoxemia is another contraindication. Oxygen therapy should be titrated in stable conditions and not during exacerbation. This is the way that we do the titration of COT. Weaning can be attempted if the underlying condition improves, but it must be gradual and closely monitored. Withdrawal should be only done if hypoxemia criteria are no longer present. So, this is for reversible processes, where we can see clinical improvement, and reevaluation in 4 to 12 weeks post-admission should be done in order to do the weaning. How? It must be with a non-abrupt withdrawal. We will reduce 0.5 to 1 liter per minute, and we will maintain if oxygen saturation is below 90%. The withdrawal trial must be done with saturation of oxygen at rest and during exercise without oxygen therapy. If we will have it available, it would be good to do an arterial blood gas test. Do not withdraw if the criteria for chronic oxygen therapy persist, there is desaturation, and we have cardiovascular comorbidities such as cor pulmonale. The weaning is done in phases. First, we have to achieve the minimum effective flow. Every 24 to 72 hours, we will reduce 0.5 to 1 liter, wait 5-10 minutes, and check the oxygen saturation again. We'll continue if saturation is above 90%. The second phase, we should reduce the hours, done when flow is already low. Recommended order of withdrawal must be withdrawal at daytime, hours at rest. Then second, maintain only with exercise and nighttime. Third, we will withdraw the exercise hours. 4, we will maintain only at night. And the last one would be discontinue the nighttime and discontinue the whole oxygen therapy altogether. The phase 3 is a withdrawal trial. So, confirmed with objective measurement, the saturation at rest and room air is above 90%. There is no desaturation during breathing. There is no nocturnal hypoxemia. And if we meet these criteria, then definitive withdrawal should be performed. If not, we will return to the last effective level. Follow-up includes clinical and blood gas monitoring with adjustment of oxygen flow as needed. We will adjust the flow at rest, during sleep, and during exercise. We will discontinue if criteria are no longer met. Something interesting is the telemonitoring, because this may reduce hospital admissions and improve quality of life, although evidence is still limited. This is a meta-analysis of telemonitoring at home oxygen therapy in COPD patients. We can see that there are some bias that limit these studies, and there are influences of demographic characteristics, and there are differences as well in support from health policies. So, in conclusions, we are gonna do a review about chronic oxygen therapy. COT is oxygen therapy above 15 hours per day for chronic hypoxemia. The goals are to improve survival, reduce dyspnea, and improve in quality of life. The indications are for a patient which has a partial pressure of oxygen in a arterial blood gas test or below 55 millimeters of mercury or 56 to 59 millimeters of mercury with complications such as cor pulmonale. Target saturation should be above 90% and 82 to 92% if the COPD patient is hypercapnic. The key message is that more than 15 or equal to 15 hours per day is required for survival benefit. Less than that does not improve mortality rate. Chronic oxygen therapy is one of the few COPD treatments with a proven survival benefit. However, it requires a strict indication, correct titration, and most importantly, patient adherence. And as we saw in this case, refusal of therapy can significantly impact prognosis. COT is one of the few COPD treatments in which adherence is critical. This case highlights that prescribing oxygen is not enough. We need to adapt treatment to the patient's social context and lifestyle in order to ensure adherence and real clinical benefit. Thank you for your attention. Here I let you study a few of the references that I've used for this presentation, and I will see you in the next one. Goodbye. Please do not hesitate to add any doubts in the comments or any further topics that you would like to discuss.